Imagine trying to defuse a bomb, blindfolded, and where a single cut, like 1 millimeter in the wrong direction, permanently costs the person their ability to smile, or I don't know, their ability to speak clearly, or even the use of their shoulder.
Yeah, the stakes are just unimaginably high.
Right. Today, we were exploring a landscape where that clean, textbook simplicity you might expect completely falls apart. We're doing a deep dive into the staggering three-dimensional puzzle of the human neck.
It really is a puzzle.
Specifically, we're unpacking the intensely high-stakes environment of head and neck operative surgery, like the incredibly dense anatomical real estate that surgeons have to navigate just to clear out cancer.
Because it is, without a doubt, the ultimate anatomical bottleneck.
Yeah.
I mean, when you look at the biology of the human body, evolution basically decided to pack an astonishing amount of critical infrastructure into this tiny space.
Just crammed it all in there.
Exactly. You've got the blood supply to the brain, the spinal cord, major nervous system pathways, the airway, the digestive tract, and a massive portion of the immune system, all into a tube that is roughly 5 inches across.
Wow.
So when cancer infiltrates that space, removing it becomes an absolute high wire act.
And the source material grounding our deep dive today reads exactly like that Bonfusel manual we were just talking about. We're looking at excerpts from the Open Access Atlas of Otolaryngology, Head and Neck Operative Surgery. Specifically, Johann Fagen's surgical protocols for modified and radical neck dissections.
It's an incredibly detailed guide.
It is. But before a surgeon even picks up a scalpel, we really have to understand why they're going into this treacherous territory in the first place. Because it's not always as obvious as, a glowing mass on an MRI.
Right, and this raises a really important question about how cancer actually moves through the body. Because a neck dissection is obviously required when a patient has clinical metastases.
Meaning what, the doctors can actively feel it?
Yes. Or see on a scan that the cancer has explicitly spread to the lymph nodes in the neck. But the more complex scenario, the really tricky one, is when the surgery is done electively.
Electively?
Yeah, based purely on statistical probability. It's done when the risk of what we call occult cervical nodal metastases exceeds a specific threshold. Usually that's around 15 to 20%.
Wait, occult just being hidden, right?
Exactly, hidden spread.
So let me get this straight. The primary tumor might be up in the mouth or the throat. The neck scans look perfectly clear, but the surgery goes in anyway.
They do, because lymph nodes act as the body's filtration checkpoints. If a tumor in the tongue sheds microscopic cancer cells, those cells float down the lymphatic channels and they inevitably get trapped in the nose of the neck.
Just catching all the garbage.
Right. And even if our imaging technology isn't sensitive enough to see those microscopic cells yet, the statistical probability that they have already migrated into that plumbing system is just simply too high to ignore. You have to clear the system before those cells can, establish a stronghold.
Okay, let's unpack this for a second. If the goal is clearing the system, how does a surgeon even know where to look? You can't just go digging around blindly in someone's neck.
Definitely not.
So the source material actually maps out the neck into these distinct zones, essentially creating a grid to locate the bad neighborhoods where these cancer cells like to hide out.
And if you are listening to this right now, you can actually trace this map on your own neck. The surgical grid divides the neck into functional zones.
6 of them, right.
6 main ones, yeah. Plus a 7th deep down in the chest, but let's stick to the main neck. Level 1 is the area right under your jawbone.
Okay.
Then if you imagine that really large muscle that runs down the side of your neck.
The one that sort of pops out when you turn your head?
Yeah, exactly, the sternocleidomastoid. The area around and under that muscle is divided into 3 sequential zones, levels 2, 3, and 4. Marching from the base of your skull all the way down to your collarbone.
Right, and then there's the posterior zone, which is level 5, basically the back part of your neck between that side muscle and your shoulder muscles.
Yep.
And finally, level 6 is the central compartment right in the middle of your throat, flanked by your carotid arteries.
Exactly. And by dividing the neck into these specific zones, a surgeon can plan a highly specific therapeutic approach. It's all based on where the primary cancer originated.
Which brings us to the fundamental strategy of the operation, deciding how much of that surrounding neighborhood needs to be removed along with those lymph nodes.
Right.
Because the source outlines 2 main surgical philosophies here, the radical neck dissection and the modified neck dissection.
The classics.
Right, so a radical neck dissection removes all the lymph nodes in those zones, but it also takes down 3 major structural pillars of the neck along with them. It removes that big sternocleidomastoid muscle on the side.
The ST.
Yeah. It takes out the internal jugular vein and it removes the accessory nerve, which powers your shoulder.
Which is just a massive loss of infrastructure for the patient.
So I was thinking about this. Is a radical neck dissection essentially a scorched earth strategy, like bulldozing an entire city block just to make absolutely sure you get all the bad actors hiding in the buildings?
That's a really dark way to put it.
Yes, whereas a modified neck dissection is more like a highly targeted SWAT raid. It goes in, extracts the targets from the buildings, but leaves the neighborhood's power lines and water mains totally intact.
That is an excellent analogy. In a modified neck dissection, or MND, the surgeon clears out the exact same cancerous lymph nodes, but painstakingly dissects them away from that muscle, that vein, and that nerve.
Wow.
And preserving those 3 structures dramatically improves the patient's quality of life after they wake up. I mean, they retain their shoulder mobility, their brain retains its normal blood drainage, and their neck doesn't have this massive hollowed out contour.
And what's wild to me is that the source explicitly notes this SWAT raid approach is completely oncologically acceptable. Like, it is just as safe for curing the cancer as the scorched earth method.
With one crucial caveat, though. It's only safe as long as the cancerous nodes haven't biologically adhered to those major structures.
Oh, like grown into them.
Exactly. If a tumor has physically grown into the wall of the jugular vein, you cannot peel it off safely. The vein has to go. But if there's a distinct tissue plane between the cancer and the infrastructure, you save the infrastructure.
Okay, which brings us to the actual preparation for the surgery. And honestly, a biological mechanism that completely altered how I think about modern medicine.
It's pretty amazing.
So the patient is put under general anesthesia, obviously, but the protocols demand the operation be done without muscle relaxation.
Right, and what's fascinating here is how the surgical team turns the patient's own central nervous system into a live interactive feedback loop.
Which is so counterintuitive.
It really is. Normally in a major surgery, an anesthesiologist administers a paralytic.
Yeah.
You want the patient's muscles to be completely flaccid to prevent any involuntary movements that could, ruin a delicate incision.
But here, they specifically need the patient to be able to twitch. I was reading this thinking, wait, the patient is totally unconscious, but the surgeon is using a little electrical probe to stimulate the tissues.
Yeah, mechanical or electrical stimulation.
Right, and if they touch a certain area and the patient's lower lip suddenly twitches, the surgeon instantly knows they found the marginal mandibular nerve, or if the shoulder jumps, they found the accessory nerve.
And the visual reality of this anatomy is exactly why that's so necessary. I mean, these nerves are not thick, brightly colored cables like you see in an idealized anatomy textbook.
They aren't color-coded yellow.
Sadly, no. They are incredibly thin, and they often blend in perfectly with the surrounding fascia, the connective tissue, and the fat.
So the patient is essentially helping the surgeon navigate the fog of their own anatomy. The body's electrical grid becomes the primary navigational tool.
It really does. And managing that grid starts with the very first incisions. Because to access all these structures, the surgeon has to peel back massive flaps of skin.
Yeah, the text mentioned these long incisions, sometimes shaped like a hockey stick or an apron.
Yep, the hockey stick or apron flap. And they elevate the skin in what's called a subplatysmal plane.
Meaning what exactly?
Meaning they are lifting the skin along with the incredibly thin, sheet-like muscle that sits just beneath the surface of your neck. That's the platysma.
But even that first step is a massive biological tightrope walk. The protocols warn that if you make these skin flaps too thin, you completely compromise their microscopic blood supply.
Which is disastrous.
Right. If the tissue doesn't get blood, the skin flap can physically die and slough off during recovery, which sounds horrific.
It is. And if we connect this to the bigger picture, it perfectly highlights the overarching tension of the entire operation. From the first cut to the last suture, the surgeon is constantly balancing this aggressive need to strip away cancer-harboring tissue against the absolute necessity of maintaining the body's basic vascular survival.
Because if a flap dies...
If a flap dies and exposes the carotid artery underneath, you are looking at a potentially fatal complication.
God. Okay, so the skin flaps are safely elevated, they're pinned out of the way, and the surgical team enters level 1, right under the jaw.
Right.
And the immediate hazard they encounter is that marginal mandibular nerve we just talked about, the nerve that controls the lower half of the smile.
And this is where the 3D topography becomes incredibly relevant. To clear the lymph nodes under the jaw, the surgeon also has to dissect and usually completely remove the submandibular salivary gland.
And the protocols specify that this smile nerve runs just outside the tough fibrous envelope that wraps around the salivary gland, right? It's in an extracapsular plane.
Exactly. So the surgeon is cutting that fibrous envelope away from the gland, moving upward, and the surgical assistant is literally just standing there, staring intensely at the patient's lower lip.
Waiting for a twitch.
Waiting for a twitch. The moment the lip twitches, they know the scalpel is riding the absolute edge of disaster.
Unbelievable.
And they also have to separate the facial artery and the facial vein, tying them off meticulously close to the gland to avoid catching that nerve in the surgical knot.
Though the text did mention a variation where they preserve the artery.
Yes, in some highly specialized variations, they actually preserve that facial artery.
Why would they do that if it's riskier?
Well, if the patient is going to need reconstructive surgery later, say, a piece of tissue moved from another part of the body to rebuild the jaw or mouth, they need a local blood supply to plug that new tissue into.
Oh, like a power outlet.
Exactly. So preserving that artery while still removing the cancer requires an immense amount of delicate maneuvering. And deeper beneath all this, they also have to find the lingual nerve and the submandibular duct.
Which they have to separate and cut without clamping the nerve itself.
Right.
I have to admit though, I was genuinely confused reading this part of the manual. If the smile nerve is safely sitting on the outside of the salivary gland's envelope, and the other major nerves are tucked deep behind it, why are we messing with the salivary gland at all?
That's a fair question.
Right, like if the gland itself isn't the primary target, why not just leave it alone and save everyone the massive risk of paralyzing the face?
That is the exact instinct anyone would have looking at a 2D diagram. But in a three-dimensional body, it comes down to physics and access.
Okay.
The primary targets in this zone are the fatty tissues and the tiny lymph nodes that are tucked deeply behind several layers of muscle, like the digastric and mylohyoid. And the submandibular gland sits right in front of all of that.
Ah.
Think of it like a massive, heavy couch, blocking your access to the corners of a room.
You can't just reach around it, you have to physically move the furniture to vacuum the rug.
Precisely. And in this case, the dust is microscopic cancer cells. Moving the furniture requires millimeter-perfect precision around the power cords of the face. You have to mobilize that gland to physically reach the nodes where the oral cancer is most likely to spread.
So having secured the smile and cleared that first zone, we follow the surgeon deeper down the neck into levels 2 and 3. And this is where the operation turns into pure anatomical detective work.
It really does.
The surgeon doesn't just dig through the fat hoping to bump into the right structures, they use sequential discovery, like they find one thing to lead them to the next.
Because the primary landmark in this upper neck area is a specific muscle called the posterior belly of the digastric muscle.
Okay.
The protocols dictate exposing the entire length of its posterior edge,
And the strict rule here is do not wander above it. Because if you drift above that muscle, you are suddenly in the territory of the main facial nerve.
which you absolutely want to avoid.
Right, but once they expose that muscle, the surgeon goes looking for the hypoglossal nerve, the one that controls tongue movement. And the protocols note this nerve is held down, almost tethered in place, by a tiny branch of an artery.
Yeah, the sternomastoid branch of the occipital artery. It basically hooks right over the nerve.
And once the surgeon carefully cuts that tiny artery, the hypoglossal nerve is physically released. And the text says that once it's released, it courses vertically and leads the surgeon directly to the front edge of the internal jugular vein.
It acts as a literal pathway.
So it's basically a treasure map. The surgeon is essentially following a structural support beam until it intersects with the main plumbing pipe. They use the tongue's nerve as a literal map to safely locate the brain's main drainage vein.
It is a perfect example of how surgeons use the body's internal logic against the chaos of the surgical field.
Wow.
But, even that logic has limits, which brings us back to the reality of biological variation.
Right.
After finding the jugular vein, the surgeon needs to locate the accessory nerve, the one that controls the shoulder. But the protocols warn that this nerve is notoriously erratic.
Erratic how?
Well, sometimes it runs on the outside of the vein, sometimes it runs on the inside of the vein, and in rare cases, the nerve physically passes straight through the internal jugular vein.
Wait. Through the vein. Let's just pause on that. A major nerve physically piercing through the center of the massive vein that drains blood from your brain.
Yep.
If you are a surgeon expecting a clean textbook layout and you just pull on that nerve, that is a catastrophic bleed waiting to happen.
Exactly. It highlights why rote memorization completely fails in the operating room. A surgeon must understand the fluid, variable nature of human anatomy. You have to expect anomalies.
So how do they get around it safely?
Well, to safely speed up the dissection once they've navigated this tangled web, the surgeon will actually use their fingers to create a tunnel directly behind the internal jugular vein.
Oh, wow.
The protocols even note that if the visual field gets really messy, the surgeon can reach deep into the neck and physically feel the C1 vertebra, the very top bone of the spine.
I can just feel the spine.
Yeah, they use it as a hard, reliable landmark right behind the soft, vulnerable nerve and vein.
It is just incredible. They are navigating by touch, by electrical twitches, by anatomical landmarks.
Okay, so for the final stage of the dissection, the surgeon moves down to the lower boundaries of the neck, near the collarbone and the shoulder, levels 4 and 5.
Right, elevating those anterior and posterior flaps. Exactly, reaching the borders of the omohyoid muscle, the SCM, and the trapezius. They have to trace that shoulder nerve all the way out, looking for the shoulder to jump to confirm they have the right wire. Because apparently there's another nerve that crosses right over it, just to make things more confusing.
Yeah, the lesser occipital nerve, or C2. It's a sensory nerve, and mistaking it for the motor nerve of the shoulder is a very common pitfall.
It's a booby trap after booby trap. The SCM muscle gets divided just above the collarbone. But right here, at this lowest level of the neck, a completely different kind of biological hazard lurks.
This is a big one.
We've been talking about blood and electricity this entire time, but the protocols state that right next to the internal jugular vein sits the body's major lymphatic duct. On the right, it's the right lymphatic duct, and on the left, it's the thoracic duct. And injuring this duct leads to a, quote, troublesome chyle leak.
Which is definitely a massive surgical understatement.
That's exactly what I thought. Troublesome, it sounds terrifying.
Oh, it is. A chyle leak is one of the most frustrating and dangerous complications a head and neck surgeon can face.
But wait, why? What exactly is a lymphatic duct doing right next to the jugular vein, and what in the world is chyle?
So this raises an important point about the intersection of our body's systems. If we pull back and look at the whole organism, the lymphatic system isn't just a closed loop of immune nodes.
Okay.
It is a massive drainage and transport network. Down in your gut, your digestive system absorbs dietary fats. But those fat molecules are actually too large to pass directly into your microscopic blood capillaries.
So how do they get into the bloodstream then?
They get absorbed by the lymphatic system first. This fluid, which is heavily loaded with dietary fats and digestive enzymes, is called chyle. It is literally milky white.
Oh, wow.
And this chyle travels all the way up to your chest in a major pipe called the thoracic duct. But eventually, all that nutrient-rich fluid and all the clean fluid from your immune system has to be dumped back into your main blood circulation.
And the connection point, like the drain pipe for that entire bodily system, is right there in the lower neck, hooking directly into the jugular vein.
Exactly right. So if a surgeon is clearing out a cancerous lymph node near the collarbone and accidentally nicks that incredibly thin, fragile duct,
That milky chyle leaks directly into the open surgical bed.
yes. And because it's full of fats and digestive proteins, it actively digests the surrounding tissues.
Oh my god.
It literally prevents the surgical flaps from healing. It creates massive inflammation. And because the lymphatic system is under constant pressure from the body's movement, it is incredibly difficult to stop the leak once it starts.
That is wild.
It proves that the neck isn't just about blood vessels and electrical nerves. It is a high-pressure, vital plumbing system for your entire nutritional and immune function.
It really makes you appreciate the silent symphony of biology going on under the hood every single second. I mean, think about it. Next time you casually turn your head, look over your shoulder, or, swallow a sip of coffee, or just shrug. You are relying on this incredibly dense, fragile, beautifully organized wiring and plumbing diagram sitting just millimeters under your skin.
It's easy to take for granted.
It really is. And the fact that there are humans out there who have memorized this 3D puzzle so thoroughly that they can literally take it apart, surgically extract microscopic cancer, and put it all back together so the patient can still smile, it is just awe-inspiring.
It is a profound level of mastery over human biology. But, looking at the sheer difficulty of this, it leaves me with one final thought.
What's that?
Well, we discussed how this incredibly complex surgery currently relies on the patient physically twitching their lips and shoulders while unconscious to help the surgeon find these nearly invisible nerves. With the rapid exponential advancements we are seeing in medical technology, how long will it be before augmented reality or advanced imaging allows surgeons to simply put on a headset and see these invisible electrical pathways glowing in real time under the skin?
Oh man.
Imagine a world where we no longer have to test the wires with a scalpel to know what they do.
Taking the guesswork out of the bomb diffusal, that would change the landscape of human survival entirely. Well, that wraps up this deep dive. Thank you for joining us as we explore the intricate, high-stakes world of head and neck surgery. Until next time, keep looking beneath the surface.